All right. Good morning, everyone. I hope I can wake you up a little bit because I think we're all feeling the effects of a Sunday morning. But it's nice to be here and nice to speak with you. My name is Alayna, and I'm the director of patient advocacy at PepGen. Thank you for Defeat Duchenne for hosting this weekend. It's been great. So for the agenda for today, Kate really asked all of us to focus on advocacy, which I think is great. So I'll go through our commitment to the community, the Duchenne community that is, and then a little bit about our technology and the current clinical study we have open in Canada. And then I'll sort of go back to how the community helped to shape that study. And then some of the early data we've seen so far from the study that's ongoing here. So our mission at PepGen is that we're committed to transforming the lives of people living with severe neuromuscular and neurological disorders with what we call enhanced delivery oligonucleotides. That is a mouthful, especially for a Sunday morning. So you'll hear me refer to those as EDOs. And our pipeline is really made out of these EDOs. So we do operate on a platform. Right now, for people amenable to exon skipping 51, we have 2 clinical studies open. We have Connect 1 that's open here in Canada, and then we have Connect 2 that's open in the UK, and we'll be opening in additional countries in the coming months. And then we're also in Duchenne looking at exons 53 and then 45 and 44. We also do have another clinical program that's not pictured here in myotonic dystrophy type 1 that we're also proud to say is open in Canada. And so what are some of the ways that we engage with the community? We really use the community to make sure that we're on the right track and that there are teachers that we're constantly learning from them. So we do try to, when it's possible, have community members come to the office. This is a photo of our office. We're based out of Boston, Massachusetts, so in the northeastern part of the US. We held a science camp earlier this year. Now that I'm looking at this slide, I should have posted a photo of a Duchenne Awareness Day panel that we held just a couple weeks ago. That was really great. We also try to make sure our doors are open to people who may not be visiting us. We manage an inbox that's community@pepgen.com that my team and myself look at. And then we also want to make sure sort of what we're saying makes sense and is relevant to you. So we make sure, in addition to ad boards about our clinical studies, that we also ask people from the community, how do our educational materials look, where we describe our EDOs and our studies and data we've received. So we're thankful for that. And then, of course, meeting you at places like this, at conferences, and just perspectives that we get from you at ad boards, or, depending on what we're working on, sometimes I'll just meet with a community member one-on-one to ask them a couple questions. So this is a little bit about our technology, and don't worry, I have a more not scientific version of it as well. So really, in summary, the EDO technology helps us solve the issue of oligonucleotide therapeutics. Oligonucleotides have been around for decades, but what happens is when they're not connected to anything or naked, that you can see here in the left-hand side with, it's kind of represented by that golden helix. If they're not connected to anything, they're not readily distributed into the muscle and don't go into the nucleus as well. And I think we've all heard this weekend and throughout our time in the Duchenne community just how important it is to try to address Duchenne at the cellular level. What our solution is we connect a peptide to that oligo, and the peptide on the right-hand side is represented by sort of that teal, that darker teal and lighter teal curve connected to the oligo that helps it get into the cell for cellular uptake and the nuclear delivery. Now, I'm not a scientist. I have my master's degree in public health. So I really like the Zoom analogy. I think we're all familiar with Zoom, and I know we have some members here today joining on Zoom. So really, the analogy we use for that is it's like if your oligo is unconjugated, you're trying to get into a Zoom meeting without the passcode, you know the meeting's going on, you see all those faces in the nucleus that are having the meeting without you, and you're getting these frustrating error messages that you can't get in. Really, this peptide helps to act as the passcode to get in, and i.e. join the meeting or deliver therapy to where it matters most. And as I mentioned, a brief overview of the studies that we currently have open. So Connect One's open in Canada. It's a phase 2 open label multiple ascending dose study. What that means is everyone that screens and decides to enroll in the study and is able to enroll gets active drug. There's no placebo. There's a 3-month treatment period followed by an open label extension. And this isn't all the inclusion criteria for it, but kind of the key ones are you have to have Duchenne and be amenable for exon 51 skipping. We right now accept both ambulatory and non-ambulatory people and ages 8 and up. Connect 2 is a little bit different. It's a randomized double-blind placebo control study, meaning that if you do enroll, there's a 75% chance you'll get on drug, a 25% chance you'll be on placebo, but then everyone will roll into the open label extension with active drug. That has a little bit of a longer treatment period of 6 months, and we're open in the UK. And you'll see the inclusion criteria is similar, except for we're accepting people ages 6 and up. And I'm going to focus today more on Connect One because that's open in Canada. And so basically, as an overview, it is an IV administration of PGN EDO 51 every 4 weeks. We do require muscle biopsies at the beginning of the study and then again at week 13. And some of the key endpoints are safety, dystrophin, and exon skipping. And on the right-hand side of the slide here, you'll see why we call it a multiple ascending dose or MAD study. Doesn't mean it's angry. It's just you'll see here, we kind of build up from 5 milligrams per kg. That cohort finishes and then goes into the LTE. Then we open the 10. And then if all's going well, we might look at a higher dose. And you'll see here also on this slide is we have the DSMB. That stands for the Data Safety Monitoring Board. That's sort of a period in each cohort where we stop and trusted researchers and investigators look at the data to make sure it's safe for everyone to continue. And I want to go into sort of how we got here a little bit. So it's really easy for me to stand up here and show you like a pretty schema slide, but it took a lot of people and advisors and thought to go into that. And so this slide is to really show who helps to make that schema. How do we go from there? How do we measure it? So we contact patient advocacy groups. I think one of the nice things about the Duchenne community is there's so many established best practices and lessons learned that newer companies from PepGen can glean from to make sure that, we're on the right track. There's, like we've heard this weekend, Duchenne registries and natural history data. So we know what is meaningful to measure in patients, where have we seen changes, and where do we think we can make an impact. Clinical advisors and clinicians, I think the great thing about some of the people who help to run our studies and advise us is they've run other Duchenne studies, they've run other neuromuscular studies, and they've seen what works and what hasn't from everything from a scientific perspective to a logistics perspective to a patient burden perspective. And then the last but not least bubble on this slide is you guys. So really the community to say, hey, that's a study that, I think myself or, someone I care about would be interested versus like, no way, no one's going to enroll in that if you require that many biopsies or that many visits, or you guys are measuring things that don't make sense to us. So it's really a team effort. And these are some of the examples sort of to dive into that last bubble, so to speak, of where we've gotten community feedback. So these are sort of 3 key pillars we've learned about. So we've talked a lot about this weekend about travel. Canada is a big country. The US is a big country. What kind of services can we offer to make sure that travel burden is minimized for the participant and the caregiver? Also, education and planning. Connect One has a pretty wide age groups. It's age 8 and up. So the way we describe our study to an 8-year-old is not the same way we would to an 18-year-old. So making sure we have educational materials and sort of resources to support that, along with a planner. As I think you all know, even if you haven't been on a study, but just regular care takes a lot of planning and appointments and schedules. So anything we can do to help participants with that. And the sites, making sure the sites that we pick have experience with Duchenne. If not, is there training we can offer them so they have experience with Duchenne? And also we really heard a lot from our participants and our ad boards to make sure on those clinic days, which are long, that there's time for quiet, that there's time for rest, that it's not just go, go, go. And I'll briefly go through some of the results from our low dose cohort of our Connect One study. So if you remember from a couple slides back, there's 3 different dose levels, and we just released data from the active treatment period of the 5 milligram cohort, excuse me. And we were pleased to see that we saw a favorable safety profile through week 13. All the participants are still ongoing past week 13. This is where we had the data cut. And we did see promising early dystrophin production in all participants. And I should say right now, it's just 3 participants. So it's still early days, but we're very excited about it. We did see a mean muscle content adjusted. Gets wordy, guys. Dystrophin level 1.49% of that of unaffected individuals after those 4 doses. We also saw mean exon skipping in biceps increase by 2.15% after those 4 doses, and then a mean absolute dystrophin level of 0.61% of unaffected individuals. So again, it's early, but I think given what we saw here and the good safety profile, we're really excited to see what happens at the 10 milligram per kg, excuse me, and beyond, which is dosing right now. And so just to thank you all again, so the clinical study participants and their families, to be able to show this data and talk about it is a big feat, and we're thankful for everyone who gave us time to do so. As I mentioned, the community and clinical advisors, we wouldn't be here today if it wasn't for them. And then all of the clinical site and staff investigators. I know we've met a lot this weekend from CHEO, and I think it goes to show just how it really takes a village, as I say. And so if you have any questions, it says visit our table, visit my table in the back. And I have more information on the study and the data if you're interested. And then these, we always accept emails at community@pepgen.com. And then if you are interested in the trials, you can email clinicaltrials@pepgen.com, and we'll get you into the right hands. So thank you.